I'm delighted to be joined this morning by Mandy Blackman. Mandy is a nurse, staff nurse, 33 years experience, and someone dedicated to her career, like so many other nurses we've spoken to, someone who's felt that she had to resign from nursing in order to speak out, in order to ask the questions that need asked, in order to highlight the problems that are now afflicting the profession that she loves in the wake of the COVID crisis, in the wake of all of the changes that have happened to procedures, to policies. And Mandy's felt it necessary to speak out because of the changes and problems and crises that she's seeing affecting nursing and affecting healthcare in the wake of the COVID crisis and due to the COVID crisis. Mandy, welcome.
Thank you, David, for having me here and having this opportunity to be able to share my experience and also what I'm seeing in my own environment, and also reaching out to my community to find out how this is affecting them.
So you were speaking out and asking questions whilst you were being employed as a nurse. You were seeing problems on the ward. You were seeing problems that were practical and that were happening daily. Could you take us through a few of these, just to give a sort of outline of the sort of difficulties you were encountering?
Yes, so for me, I was working in the private sector. That was my, I'd literally taken a post in a recovery department and was acting up as a deputy team lead for that department during the pandemic. I also do agency nursing as well, a couple of times a month to keep my skills up. So I'd been asked to work in ICU briefly for a 2-week period, even though I'm not ICU trained. I'm high dependency recovery and did anesthetics a long time ago. They wanted to upgrade our skills to be able to deal with the onslaught of what they believed was coming. So I had experience with that as an agency nurse, which was very difficult. I also worked in a residential home, a nursing home during the pandemic as a favour when staff had been sent home that were asymptomatic, and saw some harrowing things in the nursing home as there was no staff to look after these patients. Going back to my permanent position, obviously in recovery, nurses extubate patients from the ET tubes after general anaesthetic if they've had an ET tube insertion, and that's what we call a high aerosol generated spray procedure, which is something that had never really been spoken about prior to COVID. So all of this was new knowledge and information for us. A lot of the people that were working with us were either bank workers or agency nurses that had been working in ICU departments and were giving us information of things to come. Now, they had been in touch with, via Zoom calls, Italy. One of the anaesthetists in one of the hospitals here trained in northern Italy and was still having communication with the Italian anaesthetists. And what we were seeing that was coming our way, we were told, was absolutely horrific and were warning us to get prepared. So we kind of knew about the aerosol generated spray procedures and the safety concerns of that we weren't practicing before we got government guidelines by it. So we started questioning quite early on. When it did happen for us, all private surgery was halted and stopped to put in place new SOP guidelines, which are our standard operating procedure guidelines, to look after, take on NHS cancer patients, doing surgery for cancer patients. Now, if you can imagine that in a private hospital, our private hospital never had an intensive care unit, so we have to be very selective on the type of patients that we look after. It's what we call an ASA grading system, an anaesthetic grading system. So anybody 1 and 2 can be done in the private hospital without an ICU, but anything above that, 3, 4, needs to be precautious, because should that patient become poorly or deteriorate, we don't have an intensive care unit and they have to be blue lighted out to an NHS ICU. So our operating department, our recovery department was shut. We then had to put in place these guidelines that were coming through on a daily basis that were changeable, and then having other bank nurses come and work with us. We would find out that every hospital had different policies. So for times like, for example, we were having to recover in a theatre department, and 1 week, I can't remember the amount of time, say for example, it was 10 minutes. Everybody would have to go out of theatre, apart from the anaesthetic assistant and the anaesthetist, while we were extubating, because they said that the particles stay in the atmosphere for about 10 minutes and then fall to the ground. Once they've fallen to the ground, the rest of the team can come in, and then we can carry on recovering the patient, clean the department, and then take the patient straight back to the ward. So we bypassed the recovery department. So you can imagine the logistics of changing all of that. It's a lot to take in. And then a couple of weeks later, we would get a new guideline saying, oh, no, the time now is 5 minutes. And then other nurses or other anaesthetists or other consultants working in hospitals would say, but our hospital doesn't do it this way. Our hospital doesn't do it that way.
So the message that you were getting was essentially that COVID is a threat like no other, and it is so uniquely dangerous that all of the procedures that had presumably evolved and developed over decades, of hard-won experience as to how to handle patients through surgery to reduce risk, all of those procedures were essentially binned overnight, and the new procedures were brought in, and then those new procedures kept changing. So this must have been hugely disruptive.
Absolutely, hugely disruptive, especially when you realize that nurses do 12-hour shifts. And sometimes, you can't go home at the end of your 12-hour shift. If you've still got a patient that's there, that could be extended to 14 hours. And in the private sector, we were on call as well at night time after finishing your shift. And then when you've got all the nurses and the doctors coming together and then reiterating and expressing concerns, because everywhere is a different practice down to different authorities. And again, when you talk outwardly, it's different in England as it is to here, as were the lockdown rules. I mean, people wake up in the morning and you're scratching your head and you're thinking, what can you do today? Where are you? How does that work? So it caused a lot of distress and worry and anxiety, never mind the fact that these nurses have got relatives at home too. And we didn't know what we were going to be facing. Again, you would have to escalate to management your concerns, and every day there would be a new concern. For example, let me give you one. In the theatre departments that I was taken to for ICU patients, they shut ICU for COVID ICU, but the patients that were existing in that department had to be transferred somewhere else. So they opened up the theatre, some certain theatre departments to house intensive care patients. And I can tell you that an anaesthetic machine that you are ventilated on over a 24-hour period is different from an anaesthetic machine that you have an operation on. So the circuitry, the operating theatre anaesthetic machines are not geared up for 24-hour ventilation. So, you have the pipes that go through, it goes through what you call a soda lime exhaust system to deal with the exhalation of carbon dioxide and any anesthesia that's in that. We were running out of the circuits. We couldn't get the circuits because they had to be changed so often, because the ventilators are not the same as the ones that are in an intensive care department geared for 24-hour ventilation. We were having to shake them out and hang them up and use them again the next day. Now, that's just one tiny little aspect of it, you would have to question things like, well, if we're recovering patients in a theatre department, and you're saying that this aerosol generated spray lasts in the air, and that would be changeable on, you know, weekly and monthly basis, we would keep getting different guidelines for it, and then we would find out other hospitals are doing different guidelines. We would say, well, what about our shoes? What about the wheels on the bed that you're taking back to the ward? What about the bedding? And we literally got to a point where management would say to us, look, will you stop overthinking it? We need to just get through this.
It strikes me as very odd that a system which has been developed over decades, which is viewed as being the best we can make it for handling a variety of diseases. COVID comes along, it's now so different, it's so threatening, it's so beyond anything we've ever seen before. We have to throw away all the systems that we're using and think again. So we're putting people in different environments on different machines, we're having different processes, and we're rethinking it all from scratch, like on the hoof. And then when the response comes, well, this isn't, the instructions that we've got don't make complete rational sense. If the threat that you're saying is so bad in this area, what about in this area? The response to that is, don't ask, just do what you're told. This is very bizarre.
Absolutely. Even down to in the beginning, you know, face mask wearing. I mean, that is completely alien to us as nurses, because we're taught how to isolate patients. We're taught how to, you know, look after patients that are infection control risk. Never were we wearing face masks during operations to screen out viruses. I mean, that's not possible. It was there for backsplash from the patient, and also to protect the patient from coughing, etc., etc. So when we then take that not just into the hospitals but into the community, and I see people walking around with face masks are encouraging you to touch your face, to touch your mouth, and of course it's transferable on the hands. We're taught that, you know, there's a certain way to take a face mask off. You make sure that you wash your hands after it, and there's a certain place where you have to dispose of it, and that's in orange bags that get incinerated. But here we have this deadly disease that in my community, everybody's now wearing face masks, pulling them out of their pockets. I've seen people share face masks before now, going to a shop and they're like, well, I don't have a face mask. And you see them handing it over. And that blows my mind.
Of course.
But it's become so normal now.
Yes, and early on in this, the government came, and people like Whitty, etc., came and told us, you don't need to wear face masks. Face masks don't do anything. Don't worry about me wearing a face mask. And then a few weeks later, face masks are going to save you. Or then when that was proved to be false, face masks are going to save the other person. It doesn't help you, but it stops you killing the person next to you. And
it's really funny how I see society change as well, David. So in the beginning, as a nurse, when we were seeing people drop dead in the streets of Wuhan, and the fear was at the optimum. And I must admit, as a nurse, when we were faced with this, we didn't know what, you know, if you can imagine having to go to work under that fear and not to bring that home to your family. I mean, the fear was just at an escalated level that, yeah, 3 weeks to flatten the curve and we're still here.
Well, no, we're talking about face masks, and we went from then face masks to two face masks, you know, double masking. And you're thinking this makes no sense. And this is, again, it's completely alien to everything that was known. Everything that you had been trained. 33 years as a nurse.
Absolutely.
Everything
even hand sanitizers. You know, everybody now is about hand sanitizers. And as you know, I'm now standing as a candidate for Freedom Alliance, and I've had loads and loads of letters from worried parents, you know, because now their children are not being asked to wash their hands. They're asked to use hand sanitizer, and there's 5-litre bottles of this one school that I've been showing pictures of, 5-litre bottle hand sanitizer is every doorway of each classroom at the main entrance, and it's in a plastic bottle. Now, that has to have COSH guidelines, that has to have risk assessment. I know healthcare professionals that have used hand sanitizer over a long period of time that need occupational health, that have had to leave their jobs because of the dermatitis and the eczema that has occurred. And now we're asking children to do this in schools, you know, and my question is to the government, please, you know, I don't see the news being educational. I have never seen the 5 stages of hand washing being taught on the news. And again, going back to my nursing profession, this is another question that I had to ask. As a nurse, we are not allowed to administer any medication that we do not know the side effects of, contraindications, or how to deal with any adverse events of that. That's in my code of practice. If I'm not familiar, then even though the doctor's prescribed it, I'm liable if I give it, but my knowledge is not at that level to give it. So there's many times in my job where I've had to question the doctor's prescription and maybe take it to pharmacy, or maybe look online. There's a thing we have called Medusa, where it's like your index system of medication, and if I'm still not comfortable, I have to go back to the doctor and tell the doctor, look, I'm not comfortable to give this. I'm going to have to document in the notes that I'm refusing to give it. And 9 times out of 10, the doctor will look at it. He'll either give a different drug, or he would administer it himself and make a documentation of that. Now, in my healthcare profession, if you ask, and this is what I want to ask the public, if you're going to have a vaccination, ask your doctor, ask your nurse, what is a messenger RNA? Because we're not being taught it. That knowledge has not been disseminated through the medical profession. The many of us that have understanding of that now, we've had to look externally to learn that information. And even the doctors now that are coming out there to explain the information outside of the health profession are being vilified and deplatformed. So my point is, where's the education?
Yeah, we'll get to the education in just a moment. The point you were making a moment ago was about challenging authority and having a culture of challenging authority as a safety method. Now, I come from a different world. It's engineering, but we deal with risk control. And one of the things that is absolutely essential is to have a culture where if something is wrong, it can be challenged. You do not want just blind acceptance. Blind acceptance is dangerous. You need a culture where if someone sees something that looks wrong, that can be flagged up and not just ignored. Having a culture then coming in which says don't ask questions, just follow the rules, is contrary to good risk control. It's contrary to a safety culture. It's the opposite of a safety culture.
Absolutely. So we are used to critically thinking. We are used to questioning. We are used to challenging for safety, you know, and that's exactly what's happened, David, is that the platform is so changeable with COVID guidelines, regulations, also down to the whole system of lockdown. So, you know, we're not able to spend time. We don't have, everything's via Zoom nowadays. We don't have that time to interact or that space as colleagues anymore. Since I've left, now I have time to talk to colleagues about things that are going on the floor, and nurses are coming to us, and we're able to critically think. And I've had to take that nurse's cap off, actually, because even that is suppression, because we're scared to say anything that's not fact-based. Now, in our job, there may be things that haven't been fact-based just yet because we haven't hit the problem yet. But some of us critically thinking can identify future problems that we're seeing occur, and they're not being discussed. I mean, this vaccination has moved so quickly. Did it even get time to go through the ethics committee? We have serious questions at the moment that we don't have a platform anymore, mainstream, to be able to have these discussions.
And what, give me an example of some of those questions.
Let me give you a personal example. The reason I'm here is that I've had 2 family members pass away, one on their own in hospital. The second, I had to fight to get out. A third my family member is palliative care at the moment, and even that scenario has been quite challenging. My mother, let me use my mother as an example, okay? My mother didn't want the vaccination. She went to her GP surgery a couple of weeks ago, and the nurse there for 15 minutes chatted and chatted and chatted to her. My mother was expressing the concerns, but yet she was just being told it's absolutely safe, it's fine. I've had it, my husband's had it. And then here she gets told, listen, if you don't have it, you might not be able to travel and you might not be able to come to the doctor's surgery in the future. So my mum had the jab. After my mum had the jab.
That's illegal.
Of course it is.
That's coercion. That's not consent, that's coercion.
Absolutely. And let me give you another example of coercion. So I am not speaking out of my remit or speculation. These are my personal experiences. Prior to my grandmother passing away, my gran was in a residential home. She was 99 years old. We'd had a discussion pre-Christmas, and I had raised my concerns. My dad has power of attorney, both medical and financial, with my grandmother. And I remember saying to my dad, Dad, please, Nan's 99. If Nanny gets poorly, we just want to keep her safe, comfortable, and have dignity. Now, she's been locked away for a year. Please, let's not give her anything that's unnecessary. In that process, my father didn't tell me. The residential home had said to my father that if he didn't have the vaccination, my grandmother didn't have the vaccination, and my uncle, who's mentally disabled, didn't have the vaccination, they would not be able to see each other. So he went ahead and the 3 of them took the vaccination. Now, again, that's coercion. My mother actually gets quite ill after the vaccination, and we're putting it down to gastroenteritis. She's got a terrible stomach upset, she's vomiting, she's got diarrhea, she's got a headache, she feels really generally unwell for about a week. Now, obviously, recently, over the last couple of 3 weeks, I've been doing a lot of homework. Firstly, my mother was not given a PIL sheet, which is the patient information sheet, to read prior to her vaccination. Neither was my grandmother, who has vascular dementia, and neither was my father. And on the PL sheet, and I'm reading here from the AstraZeneca one, it actually says, read all of this leaflet carefully before the vaccine is given, because it contains important information for you. So firstly...
So this is something we're hearing a lot. The PIL is being withheld. It's not been offered if it's not asked for, and of course the patients don't know that it exists, so why would they ever ask?
Absolutely. Well, she was actually given the PIL sheet, so I have to say that, but she was given it after the vaccination. Now, my mum, being my mum, she's in her 70s, as I suspect many elderly people, is given quite a few lots of leaflets. Do they ever read them? No, it actually does talk in here about reporting of side effects. If you get any side effects, talk to your doctor, pharmacist, or nurse. This includes any possible side effects that are not listed on this leaflet. Now, on this leaflet, it does say tenderness, pain, warmth, redness, itching, swelling, or bruising, general feeling unwell, feeling tired, fatigued, chills, or feeling feverish, headaches, feeling sick, joint pain, muscle ache, a lump at the injection site, fever, being sick, vomiting, flu-like symptoms such as high temperature, sore throat, runny nose, coughs, and chills. Now, if we know this is an experimental drug, that's not being a conspiracy theorist. Go and find the information, people. Go to the CDC, go to the MHRA, go and have a little look what this is. And also ask your doctors and nurses. So I'd said to my mum, next time you go to the hospital, Mum, if you don't believe me, please speak to your nurse and ask her what is an mRNA vaccination? And my mum had said she did. And the nurse told her, I don't know what you're talking about. Why are you asking me this question?
Yeah.
So my mum, for the first time, had a little, she started to listen a little bit more.
That form you read out, the patient information leaflet you read out there, it didn't mention anything about changes to blood levels. It didn't mention anything about bleeding or hemorrhaging. It didn't.
No, it doesn't. But it does say here.
Doesn't mention anything about clotting. It doesn't mention anything about platelet levels.
It just mentions bruising. If you have, let me go back to it here. It talks about swelling or bruising. Now, my gran hemorrhaged and hemorrhaged and hemorrhaged. They had to give her tranexamic acid. She was transfused for 4 units of blood. Her skin was so painful to touch. Her joints were bleeding. Now, my nan didn't have past medical history of any of that. It's not until talking to other nurses who are seeing things currently come through that alarm bells ring. And again, I was never told that I could report it to the a la carte system. This is new information that I've learned. And if I've just learned this outside, my colleagues don't even know about it. So this is my flagging up concern. Let me go back to my mother. So a week after having her vaccination, being poorly, she goes back to the GP surgery to get checked out. The GP takes her blood pressure and realizes it's sky high, it's through the roof. Does a series of blood tests, and her clotting factor, so that is your coagulation, it's how thin or thick your blood is. Her clotting factors are all out. So now she's been going back for the last 3 weeks to the GP surgery for weekly blood tests, and still we can't get her blood pressure down, and her clotting factors are still not quite right. So my mother rings up the vaccination centre. Again, I've got all the information here. This is NHS Scotland, your COVID vaccination appointment. She rings them up and she tells them that she's been requested to come for her second vaccination, but she's still undergoing medical treatment after her first one. She really wasn't very well for a week. And then after that week, she's now having her bloods checked weekly and her blood pressure monitored. So she doesn't want the second vaccination. The lady at the other end of the phone had said to my mother, well, I think you're very wise. So how many weeks would you like me to give you before I make your next appointment? So my mother had reiterated it and put the phone down and came over to me and had relayed the story to me. And I'd said to her, well, Mom, you rang the vaccination place to tell them that you have had adverse reaction and still undergoing medical treatment post your vaccination. Did they tell you that they were going to record it on the a la carte system to the MHRA? My mum says no. I said, did they tell you that you can record it, Mum? Mum says no. So I said, Mum, give it to me. So I showed her what it says on here about reporting adverse reaction. So I decided to ring them myself. I rang the number that was on here, and the option was a number 4 to speak to a consultant. And when I spoke to the consultant, I reiterated that I was highly concerned that my mother had rung up and you guys had listened to adverse reactions, but you did not record it, nor did you tell her or inform her that it needs to be recorded.
What sort of response did you get from that?
I got a response of, I can't really answer your question. It should be done. But all calls are recorded, by the way. So maybe under a freedom of information, we one day will be able to get the conversations of these vaccination places. I also want to then go on and highlight another concern that I have, and this is real time that's going on now. So since I left my job and since I've been speaking out, many nurses are coming forward, and quite interestingly enough, here we've got ordinary people standing up, and we've all come together under the banner of Freedom Alliance. 37 regions, 35, I think it's 35 or 36 of us are all either current or previous NHS workers. Isn't that interesting?
Mhm.
When my colleagues are coming out and speaking out, they've been deplatformed, they're vilified. We are classed as anti-vaxxers, conspiracy theorists, and it's really alarming. You know, how did we find ourselves in this situation? Why isn't the media addressing our concerns? We don't just walk out of our jobs and our careers and our professions.
I was watching the coverage from, well, I say coverage. There was a huge march in London yesterday. Many nurses were at this march. Many people of all walks of life were at the march. There was thousands. There were tens of thousands at the march. The BBC officially didn't mention it didn't happen. It wasn't on the website. But they did have the disinformation specialist reporter there, and she was tweeting about it. And she was saying, oh, there's people carrying signs that are QAnon. She seemed to focus on QAnon. I don't think there were any QAnon signs, but someone said something that QAnon had once been associated with. So this was a QAnon conspiracy. And on she went about these conspiracy theories. And when you actually watch the videos of people at the march being interviewed, they're ordinary, rational, thoughtful people who have valid questions. And this attempt to use the CIA-derived term on them, conspiracy theorists, you're experiencing this. It's done to silence, of course. It's done so that no one will listen to you. And it only works until someone starts to listen to you, because then they hear that what you're coming forward with is based on reason and evidence and observation. And then the term no longer has any power. It only has power if it can stop people listening to you in the first place, of course.
Absolutely, and more arising when people stand up to ask questions. The others that have been too scared for whatever reason, whether that be financial, whether that be, it's very toxic environment when you constantly ask questions. After a year of asking questions and whistleblowing, our senior management were suspended and left the business. We were told that there was no safety concerns to them leaving the business, but we weren't told why they left the business. Now, that took a year of us going to management. That took a year. That was a toll on our mental health, on eventually, you know, you can't keep it up. And what we're finding now is nurses are leaving in their droves. The agencies, if you go online and you look at the nursing agencies, how many shifts are outstanding in Scotland alone, it's absolutely terrifying. So after speaking out and after trying to, you know, get across, I've worked with my colleagues for a very long time. I miss my job. Some of my colleagues might think that I've lost the plot, but when you are locked down, when you are not working in different departments, when you're not working in different hospitals, you're not seeing all the inconsistencies. And like you said, as an engineer, risk assessment, sometimes you do things long enough, it becomes normal and you no longer challenge it. And this is what we're seeing. So I had put out that I'm seeing and I'm hearing, and it wasn't my experience, that nurses on the wards, when we are giving what we call a handover, either in the morning or the evening when you start a shift, you're allocated so many patients, and the nurse that had looked after those patients requires to give you a comprehensive handover to let you know who and what you're looking after. So a brief description of that would be, you would be given the location of the patient's name, age, their past medical history, their presenting complaint. You would, it's got on here, COVID status. So it's got their COVID status. This one has got whether they are for resus or not, whether or not their condition needs escalating. And then it talks about a plan going forward. It also talks about activities of daily living. So you would be given the information on, you know, is the patient blind? Do they need assistance with walking? Are they incontinent? What their religion is, if they've got any special dietary requirements. And then it would go on to say where we are at the current form of the pathway of care, what needs to be highlighted and what you need to go on with your shift. Now, we have COVID status on that. Considering, David, last time I heard, I think it was the beginning of last week, 32 million people in the UK have had a vaccination, and different types of vaccinations as well. We know that we're using the AstraZeneca, we're using the Pfizer, and we're using the Moderna. Now, firstly, medical staff are not being taught what mRNA is. We do not know what the difference is between the different vaccinations. That knowledge is not there. We're just told that it's safe, get on with it, and then forget about it, basically. And the reason that I say forget about it is that I don't think any of my colleagues are thinking. I think that we're going to be thinking as we're seeing this tsunami hit us like a wave that is not being represented. So I question the MRHA figures of adverse reactions hugely, both my own personal experience with family and what I'm hearing and testimonies that are coming forward.
Just to interject a bit, the MHRA's own estimate is that they might catch 10% of serious adverse reactions in the reporting system. And of course, they are reporting now around 900 deaths. So if that's 10%, that's 9,000. That's, you know, it's very substantial numbers. And what we're hearing is that the sorts of reactions that you've described, including to your family members, are really quite common. And a lot of nurses are seeing this across the NHS and across the medical system in the UK.
So this is what I want to highlight, because I'm not sure many nurses are seeing it. Some of them are coming forward, but some of them are not seeing it because the critical thinking or the policies are not coming down. So the reason I brought it up is 32 million people have had vaccinations, all different types of vaccinations. When we give handover, both on the wards, and Kirsty's experience in the medical assessment unit is we're still treating symptoms. Absolutely, we're treating symptoms, but we're not asking the question, so are we making the correlation? So a nurse came forward with me with their handover. So this was 3 days ago in a Scottish hospital. This agency nurse was looking after 7 patients. And again, it's not standard that you ask the question if the patient's had a vaccination. Now, the first patient that they looked after was a 56-year-old gentleman who had ischemic heart disease and was a type 2 diabetic. Presenting complaints was chest pain. Now, of course, with a past medical history like that, it wouldn't be unusual to see somebody come in with chest pain that you would need to, you know, think that their condition is unstable or deteriorating and needs looking into. But this is the important thing. We're not asking the question, did they have a vaccination? So this nurse went to the patient themselves and asked the patient, have you had the vaccination? And the patient said, yes, I had the Pfizer vaccination. When did you have it? 2 weeks ago. So my concern is we've got a chest pain patient that's just come in, yes, with a past medical history that corroborates that. However, the patient had a vaccination 2 weeks ago. That needs reporting. The second patient, a 77-year-old who came in with rectal bleeding. This is what I experienced with my grandmother. The patient's not for resus. They've done a blood check on them and their coagulation, their INRs come back quite high. So an INR is your clotting factor. So their clotting factor is 6.1 according to this, which obviously is why your patient is also bleeding rectally. Past medical history, anemia. So when you see that and you don't think about the vaccinations, you would think, okay, so yeah, there's a and it might well be. Again, I'm not saying these are all vaccine related. I'm just saying that the questions aren't being asked. Goes to the gentleman and says to the gentleman, have you had the vaccine? And the gentleman says, yes, I did. When? Can't remember. Which one did you have? Can't remember. But the patient then says to the nurse, but it wouldn't be anything to do with that because it's safe. The next patient, a 41-year-old, no vaccine, came in with cardiac problems. The fourth patient, a 77-year-old gentleman. Now, this one is of grave concern. This gentleman has a past medical history of atrial fibrillation, ischemic heart disease, angina, hypertension, and emphysema. They presented with a pulmonary embolism. On the ward, this nurse had said that this person had a terrible nosebleed during their shift that needed to be packed. Now again, with AF and those presenting problems, it might not be uncommon for somebody to present with a pulmonary embolism. But again, if we're not asking the question about a vaccination, then we're not properly recording to the MHRA possible parallels here. So the person goes and asks the patient with a PE in the nosebleed, have you had the vaccination? The response was yes. Which one? AstraZeneca. How long ago? 2 weeks ago. Again, there's another yellow card patient that should be reported. Then I have fifth patient, 78-year-old gentleman, came in with a stroke, didn't have the jab. The sixth patient, 56-year-old gentleman. Now this is a concerning one. Came in with chest pain, no past medical history, strong, fit, healthy chap, 56 years old, confirmed heart attack. So the nurse goes and asks the patient, have you had the vaccination? Yes, they've had the vaccination. Which one? Pfizer. How many days ago? 5 days ago. They had the vaccination on the Saturday and a heart attack on the Sunday with no past medical history. Has that been flagged up to the yellow card system? Is it documented in the notes? Are the nurses handing this information over? No. The last patient that this nurse was looking after was a 62-year-old gentleman who was a step down from intensive care with COVID. They were now on 0.5 litres of oxygen and were looking to be discharged the following day. So this is a COVID ICU patient that is recovered and is ready to go home. Did you have the vaccination? The nurse asks. Yes, I did. Which one? Pfizer. When did you have the vaccination? The day before I got COVID. So in one ward, one nurse, 7 patients in a Scottish hospital, 5 of those patients have had the vaccination. And all 5 of those patients should be reported via the yellow card system to the MHRA. Now, this nurse obviously challenged it and nothing was done because it's not a policy that comes down. As I said, the only thing we have on here is their COVID status, because of course now we've got green pathways, red pathways, amber pathways, which pathway and how and where these patients are going to go. But no one is asking whether or not these people have had vaccinations. Now, for everybody out there that is questioning why we're speaking out, my gran died. My father-in-law passed away on his own in a hospital. My mum's blood is not right. We have another palliative care patient dying within our family that I won't even go into their discharge and how they've been cared for and looked after. If the government wants to silence me, that's fine. I will not be silenced when I can see that there is critical error in how we are translating information and looking after patients. Every ward, senior department of that ward should be submitting an audit, I believe, on a weekly basis of yellow cards. Otherwise, how is this vaccination program being monitored? And how is the numbers that we are seeing that the media is projecting, how can that be accurate? If this is just my personal experience and one nurse's experience of one morning shift, why is the MHRA not putting that policy down to every hospital to make them answerable to a weekly audit of what we are seeing through the hospitals.
Mandy, these are excellent questions. Thank you so much for joining me today to raise these.
You're welcome.
I know we're about out of time, and perhaps we can come back and talk to you again soon about these issues. The information you put forward here and the concerns you raise are vital and are of enormous importance. The MHRA, I noticed in the most recent report, no longer describes the vaccine as safe. It describes it as acceptably safe. This is a relative measure relative to the danger of COVID. But if we are not correctly recording any more than a tiny fraction of the adverse reactions, life-altering effects and fatal effects of the vaccine, then that assessment will of course likewise be in error. And this is information that is needed urgently by everyone in the country, because whether they've been vaccinated or not, they need to be able to make decisions. They need to be able to decide when to present themselves for medical attention. They need to decide when something happens, so there is a concern, and when it's safe to ignore a minor issue, or when it's really not a minor issue and they should be seeking medical advice. You raise vital points here. One thing we didn't get to, and I don't want to leave today without touching briefly on it. You were talking earlier about blood transfusions. Could you just outline your
Yes.
thoughts and concerns there, please?
So very quickly, as I said to you in the beginning, you know, we're very nervous to talk without fact-based evidence. It's programmed for us to not talk unless we have that information behind us. But actually, as nurses, we're critical thinkers, and we have to think ahead. You know, so the whole year that we had with all these policies coming down caused so much mayhem and confusion, because the reason that you have to think ahead is because you're thinking of potential hazards and problems and safety concerns in the future, and dealing with those before they arise. So ruminating around my grandmother and reflecting on the past 2 crazy weeks that I've had, I got thinking. My grandmother went into hospital and obviously hemorrhaged and had 4 units of blood and 1 unit of fresh frozen plasma. And obviously, David, we're seeing that the MHRA are reporting, and as you can see from my own evidence here of one nurse's experience with 7 patients, we are seeing patients that are hemorrhaging, that are having blood clots. So I have safety concerns, or questions, I should say, that I haven't seen the answers of, and I really think these need addressing. So for anyone out there that hasn't thought of this or would like to add information or give clarity to this, I'd be very grateful for. 32 million people vaccinated in the UK, and our blood banks are always crying out for blood. So my concern was, can vaccinated people give blood? My experience and knowledge is that if you've had malaria, which is a parasite, or you've been to the equatorial line where you could be around any of that, you would not be able to have to give blood. If you've had hepatitis B, you would not be able to give blood. Now, I am not a biochemist or a hematologist or working in a blood bank. I am qualified and know the dangers of blood transfusion. I'm competent to transfuse blood. And when we transfuse blood, it's a huge double checking system, because if you give the patient wrong blood that has antibodies or whatever, that is potential death. So blood transfusion is a huge area where we have a lot of safety guidelines around. So my concern was, can vaccinated patients give blood to the blood banks? So I rang up the Scottish Blood Bank and asked the question, and was told that absolutely they can. you can give blood on the 8th day after receiving a vaccination. So 7 days, and then on your 8th day, you're able to give a unit of blood.
People are presenting at hospital with blood-related clotting or hemorrhaging and blood pressure problems on at least some scale, and they're presenting up to 14 days after the vaccination, but we're taking blood after 8 for use in transfusions.
Absolutely. Now, I can't say whether or not that can be removed from the blood. I'm not qualified to say that. Messenger RNA, I have my concerns that it can't be, and that's why I'm speaking and asking the questions. This vaccination has moved so quickly. I don't believe it's gone through the ethical committees where we normally have time and we pre-think things. So for example, here's another concern. And if anybody's given blood out there, please contact us and let us know. When you give your unit of blood, do they ask you if you've had a vaccination, and do they ask what vaccination you've been given? Because again, there's different types of vaccinations that we're giving that all work differently. So the next question is, what happens if a vaccinated person receives blood? And just like the nurses aren't answering the questions and the doctors aren't answering the questions when people are coming to hospital, are we asking the questions to put on the bags? Do we know what my gran had 4 units of blood? Do I know, was that from anybody who'd had a vaccination? What vaccinations were in that blood? And will that affect, because she's had a vaccination, could that be a potential harm? What about people who have not had the vaccination? And what about people who have not had the vaccination, not just because of their free choice, but because they have predisposing problems that would be like, major allergic reactions, immunosuppressive disorders, cancer, etc. What happens if these people receive the blood? So again, as nurses outside, we can see many different areas that need addressing and looking at. And those are questions that I really want to put out there. They're the questions that are very concerning for me. And it's not until I left my profession that I could sit back and really think and follow up these kind of questions. I also found out that I've had the letters from the insurance companies after inquiring. People aren't being told, if you have private healthcare and you have any adverse reactions, your insurance is null and void. So yes, I'll leave it at that, David. There is many areas that we're seeing now, because we're moving so fast. As I say, we've been putting out fires. The last year for me for nursing was firefighting problems. Now we're taking a step back as nurses who can't work within the system because we just don't feel it's safe. We're having the time to critically think, okay, that's an area that needs looking at. This is a great area of concern at the moment, and that's why we're speaking about it. Please, any doctors and nurses out there that are looking after patients, please challenge, question, ask, why aren't we asking these questions? Why do the majority of my colleagues not understand even what the reporting yellow card system is? Why are we not being educated what mRNA is? So I think I'll just leave it on those points alone.
Mandy, thank you so much for talking to us today. It's been tremendous listening to you. I've learned a great deal. It's a very fast-moving environment. There's new information coming in all the time. You're obviously researching, and many of the people the nurses you're working with are researching. I'm sure in a few weeks we'll know much more. I want to thank you for your time today, and hopefully in a short while we can talk again and explore these important issues in more detail. But for just now, thank you very much.
David, thank you very much. It's not easy to speak. It's not easy when you're used to doing this, but thank you for giving us the opportunity of getting our information out there and to be able to ask these questions to help keep our families and our communities safe.